So the next topic, this talk is going to overlap a little bit with the last talk, okay? We're going to be, but it will introduce additional topics as well. So what I would like to do is use the area of overlap to highlight or emphasize some fundamental points about management of confirmed cases. So emphasize areas that are fundamentally important for clinical management, and then maybe highlight some areas where more clinical experience with this recent outbreak based upon sheer numbers is beginning to shed light on a little bit more about the underlying mechanisms of disease. So that will be my goal for the areas where we have some overlap. And then obviously for the experimental therapies, to talk about those in a little bit of detail, understanding that for today's ability to manage patients with Ebola, those therapies are really all very early and experimental. So just to get started, again, I have no disclosures, and the opinions that I express are mine and not necessarily those of the institutions that I have and do work for. So general principles. And again, I think these are worth emphasizing and have been highlighted to a degree throughout the conference. But the first principle is that care of Ebola virus patients should be provided in designated centers. And I think you're beginning to understand why that is the case. Because ability to care for patients ad hoc without adequate early preparation is going to result in immense amount of difficulties and potentially infection control practices that haven't been adequately thought out in practices that could result in healthcare worker exposures. And that's obviously one of the predominant things that one is trying to avoid in managing patients with confirmed Ebola infection. And so the first step in avoiding that is to establish centers ahead of time that are going to develop teams that are multidisciplinary, that include physicians from multiple different areas, whether it's infectious diseases or critical care medicine, nurses, respiratory therapists, environmental hygiene folks, all of those folks, hospital administrators, regional public health directors, all of those individuals need to be involved in the discussions in adequate planning and preparation for centers that ultimately manage patients with Ebola virus. And I think as you're going through this to understand all the nuances of doing this successfully, you're beginning to understand why that's necessary, because it's a complex endeavor. In advance of seeing a patient, and again, we've talked about this and it's been emphasized, but it's worth saying over, providers have to have experience working effectively with personal protective equipment. Everybody that's here will gain that so that by the time that they leave this seminar, they will have experience, they will have familiarity, they will understand the general premise of protecting oneself, of working from a dirty environment to a clean environment, of serial decontamination as you move from a dirty environment to a clean environment. Those things you need to experience before the first time you see a patient with Ebola. Similarly, for all of the clinical activities that you're going to be taking, that are going to be taking place, ideally, in advance of doing those, you actually participate in simulated activities, whether it's a mock patient or a mannequin or whatever. And those activities include things that will be discussed in a part of this 3-day course that are as basic as putting in an IV line, but also managing infectious diseases, spills, body fluids, all those types of things. Those types of things should be practiced and coordinated between multidisciplinary teams before this all starts and takes place. You've heard about the concept of pre-staging equipment and supplies. You need to have a designated area. And then equipment and supplies that are going to be applied to the care of patients with Ebola virus disease need to be thought out. What are we going to need? What is the extent of materials and equipment that are going to be necessary to do this well? And then have them pre-staged and planned and dedicated to those facilities with concepts for equipment that's going to ultimately come out of the room, like, for example, whether it's an ultrasound machine or a digital portable x-ray, how are you going to effectively decontaminate those pieces of equipment? And there are recommendations for that sit on the CDC website and elsewhere. But those things have to be thought about and planned in advance. And then you always have, this is the last consideration, balance the safety of the healthcare worker in any activity with your desire to provide the best level of clinical care that you can possibly do. And this gets into some of these questions that were raised, and we'll have additional discussions about, where's the extent of care? Is it appropriate to do CPR, chest compressions on somebody that's at the end stage of a shock syndrome with multiple organ failure, where we know the mortality is extremely high? Those are questions that need to be thought about in advance. So this is just a picture of our preparation for our special clinical studies unit at the National Institutes of Health. As you know, we're one of a number of centers in the United States that is prepared for and has also cared for patients with Ebola virus disease. And, we can comment on the PPE. There's a whole range of this, and the doctor alluded to the use of, PAPRs, or purified air, personal respirators. Those are the equipment that we use, not because this is an airborne virus, but because of the resources that are at hand and that we have access to them, not because they're required or necessary, but because those are what we have chosen to use at our institution. But what you can see is, and this is Marcella Ferrata, she's one of my colleagues, and this is in her full PPE. The outer gown, that is your first outer layer of PPE. We talked about this yesterday, so that when you come out of the most infectious area, that outer layer of personal protective equipment, including, in our case, the yellow gown, the first set of gloves, the first set of boot covers, all of that comes off and is left in the dirtiest area. And then what the second picture emphasizes is this multidisciplinary team training. So we actually do practice scenarios for running ACLS or codes, cardiac resuscitation. We run those scenarios so that in the event that were to be appropriate, and that was a decision that we would be prepared as possible. So that's an example of multidisciplinary training. So I tried to get, fairly succinct, get down to the fundamental principles that are likely to result in an improved outcome, reduced morbidity or mortality from Ebola virus disease. And as what we've heard and what we've observed from this particular outbreak, where we've had multiple providers have the benefit of seeing thousands of patients now, which is different from any time in the past, where we've had limited outbreaks in remote settings where providers are rotating through very frequently, is that the issue of fluid losses has come, not that it wasn't recognized previously, but is now clearly a major contributor to poor outcomes in Ebola virus disease. And this is what we witnessed in West Africa, and this is what has come out in a number of publications of expats that have been repatriated to Europe and the United States, as well as infected travelers, where diarrhea can be 5-10 liters a day, similar to what is observed in cholera. It is watery, and it is voluminous. And so a fundamental aspect, and when you lose that much fluid through your gastrointestinal tract, you lose potassium, you lose magnesium, you lose fundamental electrolytes, that in the absence of those, you have poor cellular functioning, and you're at risk of fatal cardiac arrhythmias with low potassium, for example. And so the topic here, well, the first step, how do you reduce fluid losses? Well, the first thing that you do is you stop vomiting, and this can be done. We were using metoclopramide in West Africa with a good deal of clinical success to stop vomiting. That's important to stop ongoing fluid losses, but also to allow for increased oral intake of oral rehydration solution. You all know that if you're nauseous and vomiting, nothing's going in. And so first you got to stop the symptoms, and then you got to put it back in, okay? Antidiarrheals. So loperamide. Loperamide is something that you will not see discussed very much in the literature. If you look at our New England Journal article that discusses clinical management and manifestations of Ebola virus disease in West Africa, one of the comments in that article is that our observation managing many patients with the use of loperamide in a relatively systematic way is that it reduces the frequency of stool, the volume of stool, it improves stool consistency, it reduces environmental contamination, which is an enormous, enormous issue, okay? So we did use it. We used it and saw, you know, from a clinical perspective, what appeared to be evidence of benefit, okay? Results that have to do with hard outcomes, mortality, you know, potential adverse effects. You know, people are concerned about ileus and a paralyzed, essentially paralyzed bowel with the use of loperamide. It has anti-secretory and decreased motility effects. In order to get the answers to those questions, mortality and rates of significant adverse events, we need a trial. We need a randomized trial. I'm not going to speak to that. What I can speak to is what I said, which is what our observations were, that this does reduce volume, frequency, and environmental contamination. I will say that there are data on the use of loperamide both in adults and children. There have been retrospective studies. There have been meta-analyses of clinical trials in adults. There have been meta-analyses of clinical trials in children. The studies in adults are predominantly in the setting of traveler's diarrhea, okay? So, but in those settings, loperamide works. You know, no significant, you know, adverse outcomes based upon meta-analyses with efficacy, reduced stool volume and duration, okay? That's traveler's diarrhea. The concern with loperamide originated from studies in the 1960s that were done in animals and early human studies where you had invasive bacterial pathogens, such as Shigella, where if you reduce transit time in the gut and those pathogens have an increased opportunity for invasion, you actually may induce, you know, more severe disease. So concerns arise about those studies, anecdotal reports in the case series in the literature, but then also this issue of if you're producing a toxin, for example, in the setting of Clostridium difficile, then you might induce the development of toxic megacolon and result in worse outcomes, okay? Studies for use of loperamide in combination with antibiotics for enteric pathogens, including the ones that cause dysentery. When you use a combination of antibiotics and loperamide, efficacy and safety has been established. Similarly, there have been studies that have looked at the limited data of the use of loperamide in C. diff, where they're also treated with antibiotics and loperamide, and it appears that in that setting, based upon limited data, also safe. Use alone, you know, not recommended. Use in bloody diarrhea, use in children less than 3 years of age. Also, there are issues in the literature that suggest there may be concerns there. But this is a topic that absolutely deserves additional attention because it may significantly improve disease outcome, and it certainly will reduce environmental contamination, which is a major issue for healthcare providers. So I spent quite a bit of time on loperamide. It hasn't been addressed, so we'll move on from that. So, you know, the dose of loperamide, if you look at the recommendations, the dose of loperamide is 4 milligrams or 2 tablets up front with 1 additional tablet for each loose stool not to exceed 8 tablets or 16 milligrams in a day. The way we use this in Liberia, because care had to be scheduled, similar to as you're describing in Spain, you went in on intervals at times. The way that we used this was 2 tablets or 4 milligrams separated by 6 hours, so you never exceeded the maximum dose in a 24-hour period for ongoing stool. So it was not given routinely, it was given on an as-needed basis, and that's where we saw you know, what appeared to be clinical benefit. So, okay, fluid losses. Monitor and replace fluids and electrolytes. We talked about the massive volume of diarrhea. We talked about insensible losses from fever, all these other things. These are, huge, huge volumes. We're talking about tens of liters of IV fluids, or ideally oral rehydration solution, a lot more efficient way to get volume back into people. If you can quantify it, you need to quantify it, you need to follow it. If you have the ability to monitor electrolytes, which we did not in West Africa, but we do in more resource-rich settings, that will help guide replacement of magnesium, potassium, et cetera. Keeping in mind, as we all know from our internal medicine training, attempts at replacing potassium when your magnesium is low, if you don't replace your magnesium first, you end up spinning your wheels. You don't effectively get your potassium levels up. So it's important to understand the spectrum of electrolyte abnormalities. This requires intensive nursing care. I mean, that requires a lot of attention to what's going on with patients. And it also requires the ability to do point-of-care diagnostics. You don't have the benefit of waiting for 4 or 6 hours for your laboratory to tell you what your potassium or other levels are. These point-of-care diagnostics, which are relatively simple, kit-based tests, do exist. There's a number of platforms that are out there and that are recommended. And so those are considerations. It was alluded to that these patients have systemic manifestations of widespread viral disease. They're very unhappy. They have muscle pain. They have joint pain. They have dysphagia, difficulty and pain with swallowing. Okay, and so those need to be managed. NSAIDs, as has been mentioned, in the setting of risk to the kidneys and documented renal failure that is likely multifactorial in Ebola virus, probably not the best idea. Same thing when you have mucosal injury for the gastrointestinal tract to avoid NSAIDs. So Tylenol or paracetamol, those are reasonable and options, understanding that you do have hepatic dysfunction and there should be consideration for dose modification, has been previously pointed out with the use of Tylenol, paracetamol. And obviously you can use narcotics as well under the right circumstances to manage pain. In the field, in West Africa, we also use Toradol, and that was quite effective. There have been questions about confusion and agitation. There's nothing novel here. Okay, so if you have an agitated patient, you do what you can to reduce the risk of that patient exposing or other healthcare workers or trying to elope from your healthcare facility, which could put many people at risk. And that effort to escape or elope, that was something that we did observe not infrequently in West Africa. So you can use your benzodiazepines, you can use antipsychotics, whether it's Haldol or one of the newer generation antipsychotics, but they're effective, and you just gotta get to the dose that you need to reduce agitation for symptoms, but also for safety of healthcare workers. So we talked about fluid and electrolyte, we talked about symptom management. This is a slide about complications, okay? So complications, gastrointestinal bleeding. This is one of the things that historically this has been called viral hemorrhagic fever based upon clinical descriptors over time. But one of the main things that we're observing from this current large outbreaks is that clinically significant hemorrhage is not seen in the majority of cases. And we've estimated that maybe around 5 or possibly greater % of cases actually have clinically significant bleeding, with bleeding from the upper or lower gastrointestinal tract. It does happen, absolutely. That tends to be a premorbid or just prior to death event when that takes place. Now, if that is taking place in a setting where you have advanced care capabilities, then you do have the opportunity to use blood products to manage coagulation disorders associated with clinically significant bleeding. And again, this is not a novel concept, but if you have platelets, and in general, we think about platelet counts below 50,000 when there's active bleeding to get those counts back above 50,000. Okay, so platelet therapy, fresh frozen plasma infusions to control bleeding, and obviously replacement of blood with packed red cells to the extent that that's possible, okay? Other predominant category of complications, co-infections. This is relevant in West Africa. It's relevant here. There are a lot of endemic and epidemic diseases that happen to be there and overlap with the clinical manifestations of Ebola. Malaria is obviously one of them. Those have been discussed, and that has to be considered. And if you don't have diagnostic capacity for malaria, this needs to be treated empirically. The role of bacterial co-infections. This has been hypothesized that bacterial co-infections play an important role in the pathogenesis of Ebola virus disease. That hypothesis has existed for quite some time. There are data, few data to support that that's actually quite true and very likely plays a role in at least a subset of patients with Ebola virus disease. You saw the New England Journal article where they described gram-negative sepsis in a patient with severe Ebola virus disease. There's a spectrum. Not everybody falls under that spectrum. And so we know it happens. We know it's there. And from our clinical observations, although the majority of patients presented with shock that was consistent with hypovolemic shock, diminished skin turgor, no evidence of third spacing of fluids and that type of thing, there was a subset that looked more similar to what you observe with hyperdynamic or distributive shock, more consistent with bacterial sepsis. Whether that was driven by bacteria alone or a contribution of the virus, or the virus alone, obviously when you have limited diagnostic capacity, that can't be assessed. But that's one of the pieces that we need to sort of work out in a more definitive fashion. So what is the role for antibiotics? This is clinical judgment. Clearly later in the disease course, if patients are not responding to fluid and electrolyte therapy and they have an initial improvement and they're worsening with worsening hemodynamics, blood pressure, etc., you have to think about and empirically treat, especially in the absence of the ability to diagnose bacterial infections, the possibility of bacterial sepsis. And it makes sense that we need to think about covering gram-negative enteric pathogens, which is ceftriaxone. Some people argue for the addition of flagyl or antibiotics that would cover anaerobes. So this last issue, thrush with or without HIV. So we interestingly observed, because we had such a large cohort of patients, observed thrush in a reasonable size of our patient population, somewhere around day 10 of disease. And the timing of the development of thrush actually, from a correlation perspective, correlated with what has been observed in other large series about the timing of relatively severe lymphopenia. So you have undoubtedly short-term immune suppression. Now, how many of those individuals had HIV co-infection that predisposed to thrush, or other immune deficiencies that predisposed to thrush? I don't know. But I can tell you that thrush was something that we observed not infrequently. Now, this is important not just because it's an interesting clinical finding, but when you get down to the point of having the ability to replace fluids only through oral rehydration, and you have severe dysphagia and odynophagia, difficulty and pain on swallowing, thrush is actually something that if you managed it, you may actually improve the ability to take oral intake. So those are just a few points. Many of those things that I mentioned can be implemented even with the most limited healthcare infrastructure, okay? Some of the things I'm talking about now require obviously a higher level of care, more resources, et cetera, and have been discussed previously. But if you have the ability to do this, there's, from the perspective that I'm standing, there's no reason not to do it, okay? So this has to do with invasive procedures. So as we said, everything that is done has to be balanced with the potential benefit, but also the risk to the healthcare providers. So you have to think about, if you're doing things, how do you mitigate risk to providers? Invasive procedures, we have conceived of the idea that this should require two individuals. One, perhaps administering conscious sedation to reduce the risk of a healthcare exposure from an agitated patient, certainly if they're agitated. And the second, to essentially do the procedure in the normal sterile fashion. So you have one monitoring the patient, making sure that the operator is safe and observing, and then you have one operator, and that can be applied. Obviously, safe sharp management. There's a number of sharp devices that automatically contract the needles, all these types of things. Nuances like the size of your sharps box. If your sharps box is this big and you're trying to stuff the dilator from a triple lumen catheter in, then you're forcing it. No, you need to have something that you can drop your sharps into and that you account for all of these that don't put health providers at risk. And these are standard concepts. Renal replacement therapy, that has been employed in a number of the cases that have been repatriated. Okay, this can be done. Some certain considerations for this have to do with, do you use anticoagulation or not? So oftentimes, in order to reduce the likelihood of the external circuit clotting, you need to anticoagulate the circuit either with heparin or through a citrate-based system, okay? Heparin requires typically a systemic anticoagulation, which may not be ideal in these patients that are at increased risk for bleeding. If you can get away without anticoagulation, they don't have major coagulation abnormalities, okay, that's a consideration. The issue is that if your circuit clots while you're doing this without anticoagulation, you have about 200, 300 milliliters of blood in your circuit. That's highly infectious blood. And it's also not an insignificant blood volume. So you don't want to go through that exercise too many times. Citrate regional anticoagulation can be done. This requires a lot of technical expertise. I'm not advocating for it on a widespread basis in the very least, but it should be said that this can be done and it can be done safely. And it has been done. Intubation and mechanical ventilation, we talked about this. So again, when you're thinking about these individual procedures, you need to think about each one and say, what aspects of this procedure put me as the healthcare worker and my colleagues at increased risk? So when you're undergoing the initial intubation of the patient, what about bite risk? So typically, you have to flip your fingers up. You have to get a good look with your laryngoscope of the vocal cords, and you need to advance your tube. Well, if you have your fingers in the mouth of an agitated patient and you don't have them adequately sedated or paralyzed, you are putting yourself at increased risk. So those things have to be thought through. They can be mitigated. We've thought through algorithms for this with use of sedatives. And although you may not require paralytics in your initial intubation of all patients, that might be a consideration for your patients with Ebola virus disease to reduce risk as you go through your procedure. Same thing. When you have a patient on mechanical ventilation, the circuit is a closed circuit. There's not, there shouldn't be aerosolized, which is different from non-invasive mechanical ventilation where it's not a closed circuit. You can create a aerosol around the mask, even if it's closely fitting, et cetera, et cetera. But when you have a closed circuit mechanical ventilation, you need to be conscious about when you break that circuit. So some ventilators, you can actually, when you break the circuit, they will automatically shut down, the positive pressure will stop, and you will limit aerosol generation. Others, when you break the circuit, that's still going. You got to be thoughtful about where that's going. Do you have, air control mechanisms in place for those types of things? They need to be thought through before, you begin to do these types of procedures. So those are some of the things that we think about for more advanced levels of care if you have the capacity and that's a consideration in your management. So I wanted to talk about, because it's not fair to say, this is just what you would do in an ICU whether it's Frankfurt or Hamburg or in Spain or the U.S., whatever. This is what we were able to do in the setting of a large outbreak where there were multiple patients, there were limited healthcare providers, as you've heard, and now some of you have experienced. You have limited time in your personal protective equipment because of heat exposure and fluid losses. Okay, so in that setting, what were we doing? What were we doing at the peak of the outbreak in Liberia? Every patient had their basic needs met, and that included a tent shelter, clean mattresses and sheets with regular environmental cleaning, 3 meals a day, standard medications because we didn't have the benefit of diagnostics included empiric therapy for malaria. Every patient up front, whether it is beneficial or not, got empiric oral antibiotics, okay? Those conversations have happened. They can happen again and will happen. Multivitamin, paracetamol, and omeprazole were also standard medications that were delivered to everybody that could tolerate them. So how did we manage patients in the field? This evolved over time, but ultimately you had to take a triage strategy where there were multiple patients, which hopefully and most likely this scenario will never face the Americas, but it's worth understanding and appreciating the approach that is being employed, at least in some settings in West Africa. And so patients are largely sort of broken down into 3 groups. The first group is the group that's dehydrated but is able to still provide self-care. They appear alert. They may have dry mucous membranes, dark urine. They're still urinating. Those are things that you can query about without even touching a patient. You can learn about what's going on inside with some basic questions. You give them oral antiemetics. We treated with antidiarrheals on an as-needed basis. They received oral rehydration solution and nursing care. And again, hopefully at some point we'll have some mortality data associated with this large cohort that we saw in Liberia, and those studies are coming. Okay, but clinically, those patients have the potential to do well. Okay, there's a second group that are dehydrated. They don't show signs and symptoms of shock with organ failure, but they're so weak and prostrate because of their disease that they can't effectively manage oral intake. And so that's the group that probably makes up about 5 to 10% of your patient population, that if you were able to get an IV in them, give them some short-term intravenous resuscitation, that maybe they would get back to a level where they could begin to have increased functioning and resume oral care on their own, also while managing symptoms. So if you were going to have a triage of a limited resource of IV therapy, this is likely the group that you would want to devote that intervention to. Okay, so they're responsive, but they're lethargic. They have diminished skin turgor, maybe tenting. We saw this routinely. And then you give them short-term IV therapy, nursing, and you try to get them to the point where they actually can resume self-care. The third group, and this was also alluded to, this is the group that has evidence of shock with organ failure. They have diminished or they're unconscious. They're tachypnic. The tachypnia, again, and this is an important point, and this was alluded to, we saw very few respiratory symptoms, and this is now being better characterized during this outbreak. Very few, if any, respiratory symptoms commonly seen in Ebola virus disease. Okay, so, but what you do see is tachypnia. But the tachypnia is in folks with shock, with renal failure, with metabolic acidosis, and they develop a compensatory respiratory alkalosis, and they're very tachypnic. That's a bad sign. Okay, so signs of shock. These folks, again, they have the ability to communicate. They're oliguric, they're tachypnic, they're unresponsive, and you try to provide a dignified death, which means reducing pain and suffering when you can do that, providing them dignity by cleaning them and environmental and patient hygiene, and that's some of what comes into that category. I should say about the respiratory manifestations, because this is an opportunity to talk about it, is that on whole, respiratory manifestations are not a predominant manifestation of Ebola virus disease. We know that the virus gets into alveolar macrophages, so the sentinel immune cells that are in the lung. That has been shown by prior autopsy studies. There's the limited number of autopsy studies that we have. There is minimal to limited inflammation in the lungs, even in fatal cases of Ebola virus disease, a few where their autopsy studies have been done. Where you begin to see respiratory complications based upon the observations and clinical management of a cohort of 20 or so patients that have now been repatriated to Europe and the United States is in the setting of you're downstream in the setting of the disease course. They've had a large amount of volume resuscitation. Their serum albumin is low. They likely have a degree, and potentially a not insignificant degree, of vascular leak. And in those settings, when you're giving large volumes, then you can result in pulmonary edema, which has been shown clinically to be reversible by giving diuretics. So that's one scenario where you can develop respiratory distress, respiratory failure. And the other that, again, and maybe there are others outside of the spectrum that I'm going to discuss, but at least these two exist. The other is if the patient is downstream and develops shock from whatever upstream cause, whether it's hypovolemia or a distributive physiology from a viral-mediated or bacterial infection. Once you get into the category of shock and organ failure, lung injury falls in with that, okay? Lung injury falls in with that. So acute respiratory distress syndrome, acute lung injury. So then you can begin to see respiratory manifestations, which if you have the ability to support patients, we know that in the cohort of patients with shock, bacterial sepsis, that there's still a 20 to 30% mortality rate. But the other, 75% of patients, they live with supportive care. So, again, this is a resource-dependent issue. All right, now to get into the experimental therapeutics. My caveat, I'm no expert in these. I can outline what's out there. I can tell you a little bit about the mechanism of action and where they have been used and where they are in their stage of development relative to approved use in people, and that's what I'm going to try to go through here. But to start with the idea that there are no U.S. Food and Drug Administration approved specific therapies for Ebola virus. Okay, so we have no specific therapies that have been approved. There are two therapies that are in relatively advanced stages of development that are antivirals. And by advanced stages of development, I mean they have gone through preclinical or animal studies. They have gone through early clinical phase 1 safety studies. And in some cases, they've gone through phase 2 and phase 3 studies. So the first is, which is safety and efficacy in people. The first is favipiravir, which is a nucleoside analog. So this has been shown to inhibit a number of RNA viruses, including influenza. This drug is approved for use against influenza in Japan. And it's a drug that has been repurposed for consideration of use in Ebola virus patients. It is shown in vitro and in vivo in mouse models activity against Ebola virus. And it is one of the agents that is being considered for early trials in patients with Ebola virus to see if it has safety and predominantly efficacy in Ebola virus. The second that's in the sort of more advanced stages of development is brincidofovir, also known as CMX-001. This is a nucleotide analog. This drug has gone through phase 2, phase 3 trials predominantly for DNA viruses. So Ebola is an RNA virus. It was not sort of realized that this may even have activity against RNA viruses. So it's been tested against CMV. We've done some work on it in adenovirus. But this maybe surprisingly drug has been shown to have evidence against Ebola virus in vitro. And this is an oral formulation, so there are considerations for using this under the current outbreak situation to test for phase 2 and phase 3 studies, efficacy studies in humans. So human trials are planned. The following agents are further back in their stages of development. Talk about the two that people are actually probably more familiar with. The first is ZMapp. This is a cocktail of three independent monoclonal antibodies. Those antibodies target the surface glycoprotein of Ebola virus, and the mechanism is then presumed to be neutralization of the virus to prevent ongoing infection of cells. We know that it has that it's shown to have efficacy in non-human primates, even when it's delivered up to 5 days post-exposure in non-human primates. So there are reasonable primate data. And this drug, similar to the next drug, has been used on a case-by-case basis in this current outbreak on patients, both in West Africa, but also that have been repatriated. But its use is confounded by often being used with multiple other experimental agents. And so teasing out the efficacy of this drug in the setting of a few cases where you're using multiple agents is essentially an impossible task. So it's been used as a sort of a rescue therapy. And to be honest with you, there's a mix. You know, some of those patients have survived and some of those patients have died. So we don't know. TKM Ebola, or Tecmira, people have heard about this. This is the short interfering RNA particle. The mechanism is that this binds to specific sequences in viral mRNA. So this prevents translation of proteins, so you don't get the genetic code to the end product of actual Ebola virus proteins. And so again, has shown some promise in non-human primate models. Same thing, has been used in a subset of patients, but often with multiple therapies. And we can't even come close to answering questions about efficacy. There are other agents. There's a number that fall into this category of antisense oligonucleotides. These act similar to Tecmira. They're chemically modified nucleic acid analogs. They bind to mRNA. They block gene expression. And there are some mouse in guinea pig data in this. There's a question. So the last is the BCX4430. This is a viral polymerase inhibitor. So we also have polymerase inhibitors with HIV. This has been studied in this is being studied in macaques, in non-human primates, and we'll have some of that. But these are this is very early. Neither of these agents has been used in patients with Ebola. The last topic that is important to touch on, and that I know people are thinking about, is this issue of convalescent plasma or blood. Okay. So this was first administered to an infected lab worker in 1977, and unfortunately that person did not have a good outcome. So this didn't get off to a good start in 1977. Okay. This was used in the Kickwick outbreak in 1995, and there was some encouraging evidence with that case series data where 7 out of 8 recipients survived. Then they went back and looked at the data a little bit more closely, and they realized that on average those patients received convalescent therapy about 10 days after the onset of their symptoms, which, as we now know, if you make it to 10 days, for the most part you're going to survive. So we also know that under the current outbreak, this has been used on multiple patients and has been advocated by some as a potential beneficial intervention. But the data is obviously inconclusive. But keep in mind that in order for this therapy to be effective, 2 things have to happen. Number one, that the convalescent plasma or blood that you receive has an adequate number of antibodies against Ebola. That's number one, okay? Number 2 is that those antibodies actually have neutralizing activity against the virus. If you have antibodies that don't neutralize the virus, that result in diminished infection, ongoing infection, okay. So while in concept this is a nice idea and has been thought about and is being tested in a number of other viral infections, including influenza, we still have very little data to support that this results in an improved outcome. Okay, so it's important to put it into context. Yesterday there were questions asked about prognosis. I always like this one. So signs and symptoms of shock are associated with a poor prognosis. That has been reported. we know if you get downstream to the point where if you have shock, you likely have a poor outcome, okay? So we know that one, all right. But that's been reported, and I'm going to put it up there, okay? We also know that younger age 21 and under versus 45 and over, based upon this most recent Shefflin series in the New England Journal, is associated with less than 21 is associated with a lower case fatality rate. So in the order of 50 versus 90 or so percent. Okay, so and there's a clue in there. And what we need to do is get down to data that includes smaller age intervals, so we can really understand what's happening in kids, age 0 to 5, and all the way on up to 65 and over. That kind of data exists with things like influenza and other pathogens, but doesn't yet, but will exist in the context of Ebola. And then also this one, persistently high viral load is associated with increased risk of death. But again, these are observational studies, and from observational studies, you can only glean association. You cannot glean causality. So did they die with a high viral load, or did they die because of a high viral load? We don't know. But these folks at least died with a high viral load. Okay, so those are some prognostic factors. This is worth discussing. We've talked about it. It's worth bringing up again. So viral persistence in body fluids after evidence of clearance from blood. So if your blood test, your PCR of blood shows that it's negative, you're cleared from the blood, we now know that virus can persist in certain compartments, okay? Urine, this has been documented by the co-infection case that was reported in the New England Journal from Germany. It can persist in urine 9 days after evidence of molecular clearance of blood. That's live virus. We could talk about that. I mean, if you develop acute tubular necrosis and then you get back into a non-oliguric phase of renal failure and you have flushing out of your kidneys and your organ, are you going to have some virus by molecular and live, detection? That's possible. Semen, this has been described previously in previous outbreaks and has now been observed with the present outbreak, and it's been seen live virus in semen up to 82 days after clearance from blood. We also know that virus can persist in sweat and conjunctiva for conjunctival fluid after clearance from blood based upon molecular techniques. Okay, the last two are based upon molecular techniques. What implication does that have? You can have neutralized virus, even if neutralized virus that doesn't have the ability to go on and cause ongoing infection in the same host or place other people at risk of infection. That neutralized virus you can pick up by molecular techniques. So just because it's there by molecular techniques doesn't imply that those folks are infectious to other people. It's important to understand that distinction. So in the environment, we want to know the answer to this. We don't have the detailed studies. Yesterday it was shown there were some data that talk about persistence of virus in the environment. This is we know it's an RNA virus. RNA viruses on the spectrum of pathogens going from RNA viruses, enveloped RNA viruses, okay, non-enveloped RNA viruses, bacteria that form spores. If you take along that spectrum, envelope viruses to bacteria that form spores, these over here, the envelope viruses, are most susceptible to destruction in the environment, whether that be exposure to ultraviolet light, to drying out, to decontaminants. That's going for us in this whole thing. These things can be readily destroyed in the environment. But how that varies depending upon the amount of ultraviolet light, the amount of humidity, the temperature, the amount of the amount of organic material. We know that virus does well in organic material, dead bodies, for quite some time. So this is going to vary. Dried out viruses on surface estimated in the order of hours, okay, in the absence of things that would destroy it. In organic material, obviously quite longer. We know that dilute bleach solutions and other disinfectants are effective at destroying envelope viruses. This was shown yesterday. I thought it was worth putting up again, okay? So again, this represents I would argue, the severest end of the spectrum of Ebola virus disease. So this is a patient that was managed in Germany that had access to a full complement of supportive care services. They actually had evidence of initial improvement in their clinical syndrome sometime around day 14 to 16, when the viral load in their blood by molecular techniques became undetectable. Their clinical syndrome worsened, and they suspected the possibility of secondary bacterial infection. They identified a gram-negative bacteria in the blood. We're still waiting on what that organism was. But then they had a worsening in the clinical syndrome. So this person was then supported and ultimately survived. By serial testing of the body fluids, we gained some important information. So even though virus was cleared from blood by day 17, 16 or so, virus in sweat, the black line, and virus in urine, as detectable by molecular techniques, in urine persisted by molecular out to day 30, and in sweat out to day 40 by molecular. The urine, that data was matched with actual virologic data, where we know that the virus also persisted in urine, live virus, for up to 9 days post clearance from blood by molecular techniques. So that's important. And then you see again the blue and the green lines, the titers of the antibody response to IgM and the IgG. So this leads us to a conversation about discharge criteria. So we have our discharge criteria as they exist at present, and then we have discharge criteria as we're beginning to think through how do we integrate newer knowledge about viral persistence in body fluids over time into existing discharge criteria. So discharge criteria varies depending upon the organization and group, but they have similar themes. So Doctors Without Borders or Médecins Sans Frontières, 3 days without symptoms and a negative Ebola virus PCR from the blood are criteria for discharge. The WHO, symptom resolution and 2 negative PCRs from the blood separated by 48 hours, which, if you do the math, comes up to at least covering the MSF criteria. And the CDC, for their decisions in the US, follows these at least, but then also considers on a case-by-case basis the decision of discharging or not discharging, okay? But you know, obviously the impact of persistence of virus in body fluids over time is going to require us to think through our recommendations for discharge, how those recommendations apply to different patients with different manifestations, severity of disease, pre-existing conditions, all of these things. The few data that we have are from individual patients that often tend to be, you know, critically ill that were supported. So how generalizable are those data to the general population? We got to be careful about making incorrect assumptions. But what it does tell us is that we need more information. And I'll leave it at that.